when somebody's stress response to a cancer diagnosis is overwhelming to the person and they're unable to function because the brain wants to survive, the body wants to survive, our DNA wants to survive.
Welcome back to What I Wish I Knew, a Cancer Starter Kit podcast. So obviously we love to share things that can help make your cancer journey just even slightly better. And the thing that we're covering today helped me so much, and it was EMDR. And we have the perfect guest to talk about this, Dr. Christine Sells, and she's been a licensed psychologist for over 30 years, and she is the founder and director of training at this EMDR Center of Southern California. So she helps train other mental health professionals get certified in EMDR. So, Dr. Christine Sells, thank you so much for being on. I'm so excited. Is this a funny transition?
No, it's fine. Thank you very
you.
much for having me. I really appreciate it.
Of course. So let's start super foundational. What does EMDR stand for?
Wow, it's a very interesting acronym. EMDR stands for eye movement, desensitization, and reprocessing.
Okay. And it's interesting too, because when I went through EMDR, I was like expecting just like, my eyes going crazy, but I did like the tapping modality. So there's other things besides just eye movement, or how does that work?
There are. Our research shows us that actually eye movements provide the greatest mental flexibility and insights and associations. However, the other ways, such as tactile, the tapping, as well as auditory, are effective. And it's suggested that the eye movements are the primary way to effectuate the brain getting kicked into investigation mode. But if a person has migraines, or they get dizzy, or they have some sort of an eye disorder that prevents them, then we, tend to go with the other ways of, promoting the stimulation of the brain, left hemisphere, right hemisphere, prefrontal cortex, all the way back to the cerebellum. The idea is to kick the brain into investigation mode. But that's really just the sexy part of EMDR. That's as we call it, the trauma confrontation piece of it.
Yeah. And okay, so can you walk me through what a EMDR session looks like typically?
Well, to answer your question, I think I need to let you know that there are 8 phases in EMDR. And phase 1 is history taking and assessment of what's going on with the client. So that would be the conversational turns, maybe the psychosocial history taking, paper pencil testing to screen for dissociation, and then any other paper pencil tests that are required based on the presenting issue that the person comes to the therapy with. So that's phase 1, and that can typically take anywhere from a couple of sessions to 4 or 5. It just depends on what the person is bringing to the table, in terms of what they need. And then phase 2 is really setting a person up for success before they get into the trauma confrontation piece of it, which is the sexy part, where the bilateral stimulation happens in fast mode. In preparation, the person is really getting their system more and more resilient, because the idea here is that we don't want to pass through anything in the person's system that is going to derail them, dysregulate them, make them decompensate. So we need to make sure that their processor is stronger or resilient enough to pass through what needs to go there.
What's decompensate mean?
You told me no big words.
Sorry. I'm just like, is it similar to dissociation?
They're related.
Okay.
They're not synonymous. They're not the same thing. But when somebody decompensates, it means that they go from their mm, regular ability to function in daily life, and they devolve. They get less able to function, and that can happen right there in the EMDR session. And it could also happen more typically after the trauma confrontation part of EMDR, which is phases 4, 5, and 6. But let me get back to phase 2. So phase 2 preparation of the client is going to get the person built up with resiliency in their system. And there are particular EMDR resources that we provide. And that also includes psychoeducation, connecting up with um, community services, support groups, etc., as is needed and tailored to the client. And then really phase 3 is setting up for the trauma confrontation. That's a short phase, and it really ideally will take about 7 to 10 minutes maximum. And that's just getting the person's what we call maladaptive memory networks lit up so that the person is starting to actually recount on conscious level as well as subconscious levels the traumatic or the upsetting thing that's being worked on in that what we call reprocessing session. So that happens for about 7 to 10 minutes, this phase 3. And so we're asking the person about, what's the image associated with the disturbing memory. We're asking about the negative self-evaluation. We're asking about what would you like to believe about yourself. We're getting baseline measures. We're rating how strongly the thing that they would like to believe about themselves is at that particular baseline moment, given the image that they drew up, which is the worst part of the incident that we will be reprocessing. And we will also talk to the person about the overall effect of how disturbing it feels right there at baseline. And we'll ask, where do you feel that in your body? Because we want to get all of the state-dependent memory activated before we actually start the bilateral stimulation, whether that's going to be through the eye movements, tactile, or
Audio,
audio.
right?
Yeah.
Yeah. And so the audio is like you put headset on and like
You can, but literally when somebody's doing EMDR and it's through a remote venue, a remote platform.
Oh, and you're snapping yourself.
Yeah.
Okay,
You
interesting.
can take paper cups, tap on the end of paper cups.
Yeah.
Yeah.
And so during phase 1, like just during the assessment of someone, like who do you turn away from EMDR? Like do they
Nobody gets turned
Okay.
away. That's a really good point because some people come in thinking EMDR is just the eye movements, the fast eye movements, right? And it's not. That's just one component of EMDR. So if somebody has a very complex internal system in which there are repeated traumas throughout life and they didn't get the advantage of building up resiliency in their mental and emotional, ways of being, then we have to hang out and spend a lot more time in phase 2 preparation. But that doesn't mean that they're not doing EMDR. It also doesn't mean that the person can't find relief. In our research, we find that 50 to 80% reduction in symptoms can happen just through the preparation phase of EMDR when the preparation is specifically tailored to what the person's needs are.
That's incredible. So before the EMDR even really begins,
Yeah.
they already have made so much progress.
Yes.
Wow.
And sometimes just naming what is troubling for the person and being able to get a hold of that makes it less daunting.
Yeah, for sure. Okay, so that was what phase are we at now? Because there's 8?
Well, phases 4, 5, and 6 are the reprocessing phases.
Okay.
So phase 4 is what we call desensitization. And that's when we start the bilateral eye movements or the bilateral stimulation of the brain through tactile or audio. And the brain begins to investigate itself as to what is going on here. And so just a little slice of what's happening is conscious. The rest is subconscious. So the whole brain is getting stimulated and kicked into investigation mode. This being said, it's very important when a person is doing the trauma confrontation piece of EMDR that they're operating within their tolerance level. And if a person gets outside their tolerance level, the therapist, the EMDR therapist, is meant to get them back inside their tolerance level before moving forward, because there's no reconsolidation that happens when a person is not able to what we call dually attend. And during the reprocessing phases, the individual is dually attending to the eye movements or the other means of stimulation, as well as the memory that they're reprocessing. And so when someone goes outside their tolerance levels, they've lost their ability to dually attend. And then nothing's happening, and it can actually hurt a person if the therapist goes forward with the reprocessing and is not aware that the person is outside their tolerance levels.
Dang.
Some people are very obvious about that, but then some people have learned through life that they don't show their disturbance or their upset.
Absolutely. And for like cancer patients listening to this, what kind of disorders or like things happen during a diagnosis and treatment that may kind of like give way to maybe you should do EMDR?
Well, I think that once a person is in a diagnostic framework, and I'm assuming what you mean is that somebody is with some kind of a healthcare professional, not necessarily with a mental health professional.
Yeah.
And I know that for the listeners, we're really talking about an oncologist, perhaps, or maybe even a family physician that caught, the markers initially. So I think that EMDR is really well saturated in the healthcare system now. It's not such an esoteric treatment as it originally was back in 1989 when it was founded by Francine Shapiro, who has her own cancer journey story that she had. Yeah, we can get into that maybe a little later.
Yeah.
But yeah, so healthcare professionals might do well to think about the different kinds of treatments that are available to assist somebody with the stress response, because that's a huge factor when somebody gets a diagnosis of cancer.
So after a cancer journey, you can kind of see that there's like PTSD, like
Yes.
anxiety,
Yes.
depression
Yes.
that come out of it.
Yes.
And then EMDR can kind of be the intervention to be like, well, we can kind of reprogram this in your memories so that you're not just like going about life with that, right? Like, because I remember I did one treatment of chemotherapy. It was like
Yeah.
a one week 24/7 infusion in the hospital, and there was this one, like, I still remember it, but it's not triggering anymore, but it's like this itch that was like a full body itch I could not escape, and that was one of the worst parts, honestly, that and like the actual like pain associated with it, but that itch, because it would come back later. Like I remember like when I'd just be laying in a certain position or doing something, it's like I would have a memory or something would trigger like the itch, and then it was like I was back in the hospital again and whatever, and it was like it was the closest I've been to, I guess, like PTSD regarding cancer. And so that's when I really started like looking at EMDR, because it was like, well, I don't want to do this anymore because it's like debilitating. I'm like, whatever, if I get that trigger thing, I'm like, out of capacity. I need to just focus on trying to like ground after that.
Yeah.
So, and through that, it was like going through these sessions and really coming down to a place where that trigger was like a 0. So what are people coming to EMDR for? Like, is it typically PTSD? Is it like the whole spectrum of emotions, or can it be smaller than these like huge life changes too?
You just answered the question. Yes. PTSD was the original reason why Francine Shapiro gathered up her dissertation data, and she utilized Vietnam vets, and the treatment was resoundingly effective. And her PhD dissertation just took off, and there was a explosion of research that happened after that. And then in 1991, she came up with the reprocessing end of the theory and the adaptive information processing that we go through when we're utilizing EMDR. And then from there, the research really expanded in an evidence-based way the application of EMDR not only to PTSD, but at first it was expanding into many different anxiety disorders. Then came, depression, personality disorders, as well as, just general malaise when somebody is subclinical and they don't qualify for maybe a, depression diagnosis or something like that.
I remember on one of the podcasts I listened to you on as a guest too, you talked about even like rejection, repetitive rejection. Can you like tell me more about that too?
Well, really, in order to answer your question in a meaningful way, I need to talk about a bit about how we target what we work on. And so when a human being is going through thousands and thousands of early um, dyadic mother to daughter, father to son, caregiver to child, significant caregiver to child, thousands and thousands of interactions, the child's brain is not only developing neurologically, but the child's brain is making sense and making meaning out of experience even before language develops. And so by the age of 4, what we know through attachment research is that human beings have a fully functional theory of mind, which means I have a theory of myself in the world. I have a theory about myself in relation to other people. I have a theory about what I can expect in the future. And I have a way of adjusting my behaviors to survive and adapt in the best way. So part and parcel of this is the development of belief systems. And so when you referred previously to that itch that you originally felt in the hospital bed, and then afterward when you were laying in a certain position, that's state-dependent memory. And what is disturbing that goes along with that are a whole host of other things, and perhaps, and importantly, belief systems. So in EMDR, we really work on identifying a maladaptively linked belief system. And then we organize how we deal with that through the targeting sequence of the disturbing memories that are neurologically linked in the system to this belief system that develops, in full form with verbal memory from, like fully about age 4, but even before that, when language acquisition comes online. And we can really pinpoint how a person develops symptoms because looking at how the person's meaning making, the adaptive information processing that Francine Shapiro began to talk about in 1991, how the AIP, that's the acronym, how that develops over time. And when experiences are maladaptively linked in the brain, the meaning making system sometimes will sprout up a symptom out of that. Now, I'm not intimating that cancer at all comes out of faulty, or not faulty, but maladaptively linked belief systems. Not whatsoever. What I am saying is that when somebody's stress response to a cancer diagnosis is overwhelming to the person, and they're unable to function at the level that they were, vastly decreased, it can definitely have to do with underlying maladaptively linked belief systems
So
in
tell
their
me
system.
more about the belief system part of it. Like, is that kind of association? Like, this thing happened, I'm associating that it's bad or that I suck. And then it's like, that's the belief system that goes with the event? Or would you dive deeper into the belief system part of it?
Yeah, I don't want to get so granular that it's a turnoff. So I'm gonna do my best here. So I said before that human beings are meaning making machines. We make meaning out of our experience so we can survive and adapt, because DNA wants to replicate itself, right? So uh, our belief systems are very pretty well established in a functional way by the beginning of the third year of life. Third year of life. That's when a person's attachment strategy is fully formed. Now, it's changeable throughout life, but it takes a lot to change that. And the belief systems that go along with the meaning making, based on the interactions that happen in the first full 2 years of life, are also changeable. But what happens is that, let's look at it this way. We have a huge file cabinet, and we have things filed in terms of how this fits. How do I survive and adapt based on what's happening? When experiences are emotionally activating, and I don't mean in a necessarily positive way, those meaning making experiences get put into the file cabinet and filed under certain belief systems. And then when life goes forward and more situations happen, it goes into that same file within the big file cabinet.
So it's kind of like we go about life, and if we have a certain belief system, we interpret everything that happens under that belief system. So if there is like a belief, and I know you didn't want to get granular, but if there's a belief of like, oh, I'm an unlucky person, then everything that doesn't completely work out, like we try to confirm that with that belief.
Yes.
Okay.
I don't want to say, though, that the different files in the file cabinet don't cross-pollinate.
Yeah.
The brain is so complex, and the neurological system within the brain is highly complex as well, granted. The belief systems can intermingle. So it's not a one-to-one.
Yeah. And so how does the bilateral stimulation in EMDR help us become less traumatized?
Well, when we start phase 4, the desensitization part of it, that's meant to get the disturbance down to 0. And in EMDR, we want to make sure it's at least the beginning of a pattern where you get a 0 disturbance twice in a row before you move on to the next reprocessing phase. So when we're doing the bilateral eye stimulation, or the other means through the ears, or the tactile, the brain, as I said before, gets kicked into an investigation mode. What usually, but not always, and particularly with children, this pattern doesn't adhere really. But what happens usually at first is the emotional information processing. So that can usually take about 10 to 15 minutes, in which the disturbance is intense and it's not fun, right? And the therapist is checking to make sure that the client is within their their limits of tolerance, so that the dual attention to the eye movements as well as what's being processed is evenly hovering, or evenly hovering enough so that the emotional disturbance can be moved through. That's usually dissipating after 10 minutes, and then the brain begins to calm down. And what happens at that point is, on a subconscious level, the brain is saying to itself, I'm watching some boring balls go across a screen, or my therapist's fingers wagging, across my face, or I'm just hearing sounds and I'm thinking, my brain is thinking in certain ways about this memory, and this isn't happening now,
Okay,
right?
so it makes it more present.
Right.
It doesn't
It
draw
it
you back.
goes from this,
Mm.
I'm reliving this, to I'm remembering this.
Mm.
And the brain's calming down as that's happening. And then the AIP system, the adaptive information processing system, really comes to the fore. And the parts of the brain where neurologically linked, positively adaptive memories live get relinked with
Mm.
this disturbing memory. So that's where the reconsolidation piece comes in.
And what does reconsolidation look like on a appointment? Like in an appointment, I guess.
Yeah. So, um, is it okay if I use the example that you gave
Of
me?
course,
Okay.
yeah.
All
You could
right.
do a better one or something.
So, with the memory that's disturbing, where you couldn't escape during
Yeah.
the infusion, you were
Yeah.
locked in
I was
and you had
trapped.
nothing to do. You were
Mhm.
so trapped. There was no escape, right? And it was highly, highly activating. When a person, or when you reprocessed this, chances are it was pretty intense at first. And then after about 10 to 15 minutes, your brain and your body began to calm down. And then more adaptive mental associations were allowed to come in.
Mm.
Insights, realizations,
Yeah.
associations that were in keeping with the memory, the factual pieces of the memory, but it's then eventually no longer traumatizing. And that's when it's reconsolidated, right? There are two other phases of the reprocessing where we're really attempting, like phase 5 is the installation of this preferred belief, the positive cognition, we call it, in which the positive adaptive information processing is allowed to come in and link up very strongly, so that the person gets themselves to link up this preferred belief about that incident. And then in the
Mm.
last phase of the reprocessing, that's called the body scan phase, in which the sensory motor networks are really the focus, and the residual maladaptively linked neurological connections with this memory are being cleared out. So the body doesn't have any disturbance anymore either. And in your case, that itchy sensation gone.
Yes. And so everyone has different like triggers, right? For what can
Yeah.
kind of incite one of those memories and go down that
Yeah.
rabbit hole.
Yeah.
Interesting. And so when people like hear about EMDR and like are just because it's very like vague, and you hear about it in all of the amazing things that it can do, but a lot of people like I remember when I first heard about it, I was like, oh, I mean, it sounds great, but like what's actually happening, whatever. What do you think's like the most misunderstood part about it?
Hmm. Um well, many common notions are that EMDR is just an intervention,
Mm.
that it's just the fast bilateral stimulation, that's the EMDR. It's not. It's a whole system of therapeutic, a therapeutic modality, really. So that's, I'd say, the number one reason that people misunderstand EMDR. And many people come in to EMDR treatment thinking, well, if I don't get the bilateral stimulation right away, it means that, I'm not worthy, or I don't qualify. It's nothing to do with that. It's that the EMDR therapist is working to make sure that it's safely applied, and readiness criteria need to be met, because if somebody gets derailed by that intensity, the last thing we want is for somebody's life to become less in quality than when they came in for treatment.
Yeah,
And that's a real concern.
totally. And it's like, although I first went into the EMDR just trying to like, I was reading a lot about how suppressed emotions can really affect our immune system and
Mhm.
our nervous system and all of this. I was like, okay, what can I do to alleviate that? What can I do to target that part of my healing? And that's when I first kind of got into EMDR. But upon doing that, it was like just going through and getting anything triggering out. And although it was like the focus was kind of like the cancer related, but like everything that had ever happened was also coming up, and
Mhm.
it's like constantly through each appointment freeing myself from some of
Yes.
these things that
Yes.
I didn't even know were there.
Yeah.
And I think after I started EMDR too, I was I like unlocked my emotions. It was like I was so separate from them for so long, and then upon starting, it was like, "Oh, now I can like release them. I can cry." And I was
Yeah.
like I was making up for years of not crying, and especially around people or whatever. And so it was very unveiling of like the different behaviors I'd have too. It was like for so long I'd be like, "Oh, I don't know why I'm feeling anxious right now. Nothing's going on. I have no idea why this started." Or I'll be like, "Why am I irritated right now? Why am I sad right now?" And there was no connection.
Mhm.
But after EMDR, I was like, "Oh, now I can see why that's happening." It's like connection after connection. Can you talk a little bit about the behavior changes you see of like people pre EMDR and people post EMDR? What kind of behavior changes do you see in
Mm.
them?
I think that's a wonderful question, by the way. Thank you for asking it.
Anytime.
One of the biggest changes that people do see as a result of EMDR, no matter what diagnosis they come in with or what referral issue they come in with, is a greater ability to regulate their emotions. In phase one history taking and assessment, one of the things that we do is to find out what is the person's thinking feeling balance. And some people, based on their life history and their meaning making system, are really heavily loaded on thinking and very light on feeling, which means that they substitute thinking for necessary feeling. So they're not able to feel into their thoughts. We also have folks who come in who are just the opposite teeter totter, right? So people who feel a lot, who get quite emotionally connected to distress and are stressed out a lot, but they're not able to seize on the meaning of their experience. And so they're not able to think into their feelings. And when this balance gets relatively righted, the person can then, as flexibly needed, think into feelings and feel into thoughts, to say it simply.
Wow. Yeah, and finding that balance
Yeah.
because it is like my friends and I talk about all the time of like some of us will like just put too much logic and
Yeah.
not even comprehend what's going on
Right.
internally because it's like, "Oh, I shouldn't feel like this," or
Right.
"I don't get to feel like this." And then the other people just like you said,
Right.
feel everything but don't know what's going on. So,
Right.
restoring that balance is so important for everything that comes into our
Yes.
lives.
Yes.
What would you say is the difference between EMDR, CBT, talk therapy, like
Mhm.
all of the, I mean, there's so many different types of therapy.
Yes.
What is like the biggest difference with EMDR?
Well, there are many evidence-based treatments that are effective and many reconsolidation therapies that help people find real lasting relief from their problems. EMDR is not the only one. And EMDR is friendly to other therapy modalities, CBT, psychodynamic, narrative therapy, exposure therapy, friendly to the concept. So we don't poo poo or exclude those as valid whatsoever. The difference is in the way that we conceptualize the person, the mental model of what's going on in the person's internal system, and then the systematic way that we address that through the 8 phases of EMDR. And that reminds me, I didn't get to phase 8.
Yeah, that's
So-
perfect timing now.
So phases 7 and 8 are, phase 7 is closure. And that really happens at the very first EMDR session, whether there's been any resourcing or anything at all going on. In the closure phase, the person is able to debrief with the therapist what's happened. And then the therapist is going to help them understand what might happen between that now and the next session based upon what was done, right? So every single session will have a closure phase. Phase 8 is about reevaluation. So when there's session 2 and beyond, there's always a reevaluation that happens at the beginning. And the therapist is functioning on 2 different levels with that phase 8 at the very beginning of the session. So number 1, is the treatment plan still valid as is? Because a treatment plan is a living document, and it needs to be changed based on how the person responds between sessions in their overall life. That's the first level of reevaluation. The second level is about reevaluating the intervention and how that affected the person between sessions. So that's going on 2 different levels. And based on that, what needs to happen next could be, readjusting the treatment plan or troubleshooting, for example, a resource that was given and the person had a technical issue with it. And so working on that all the way over to, wow, it's now come out that the person is having real challenges in finding the motivation for change. So that may need to be then the focus. That we call that secondary gain. But the reevaluation phase 8, is vastly underestimated, I'd say, by many clinicians.
And so the secondary gain, what does that mean?
What am I getting out of my problem? What am I getting out of this that prevents me from facing what I need to face in order
They're like, is
to
it
get
worth
better?
it? Is like this process worth it? Is that the question they're evaluating?
Well, this is the divided mind we need to talk about,
Mhm.
because we all have our consciousness and we all function off of the notion that I am just what I'm thinking right now. However, the subconscious mind is most of our experience, going from our heartbeat, the regulation of our lungs without conscious thought, to the operation of our belief systems in the way that we behave, to our preferences, our motivations, our struggles that we don't understand. So secondary gain is really on 2 levels. If I, let's say, if I confront, let's say, my needle phobia, right? Let's say I'm treating somebody who has a needle phobia and they're going through infertility treatments. Okay.
Mhm.
So if they don't do the preparation exercises and they have a reluctance to making themselves get to a point where they can give for example, progesterone shots to themselves. That may mean they, if they're having a challenge through conversational turns with a therapist, it may come to light that there's more to this than meets the eye, such as, well, then I get to spend more time with my mother-in-law and my husband because they have to give me the shots.
Mm-hmm.
There may be something, some belief system in there I can't. So we need to dig in to see why it's super challenging sometimes. And it's not everybody has secondary gain about letting their symptoms go or letting their problems go.
Yeah. So it's like for this to work though, people need to want to change. They need to be
Yes.
open to
They
change
need to be ready.
and ready.
Because sometimes somebody may want consciously, but subconsciously they're not ready because there's a lot going on behind the scenes in the subconscious mind.
And it's like some of the trauma that happens to us, we like create it as part of our identity as well, which is
There can be an over-identification with the victim role.
Yeah. Tell me more about that too, like the victim role.
The victim role, as I understand it, is very heavily laden with a passive stance, right? And this has happened to me rather than an idea that my experience flows from me. My interpretation of my experience flows from me. And when somebody is in that way of thinking of being a victim of whatever, whether it be a person crime or a diagnosis, or I grew up in my family of origin and I got a crappy hand, and it could be anything really, right? So to make that transition from a victim mentality to a thriver mentality requires an active transition mentally,
Yeah.
a consciously directed active transition that the relationship with the subconscious mind needs to be the focus, and a pointed and a very specific focus with what's going on in the subconscious mind that's working at odds with the conscious mind.
And it's difficult too with when you talk about the victim mentality in a way, it's like I just got back from a Vipassana, so we're like silent
I'm jealous,
meditation.
by the way, of that.
Really? You should
Yes.
totally do it. I
Yeah.
know it's probably hard to find 10 days where you're completely disconnected, but I feel like you would find some crazy stuff because of your background and because of like all the knowledge you have too. But one of the things we have like an hour lecture and every evening, and one of the things that the teacher was saying is like, okay, yeah, you are a victim sometimes if like someone does something to you, right? And it's like really traumatizing. And then he was like, but they did that to hurt you one time, and then you are like letting it hurt you for years and years. And I think that really hit me, because it was like, yeah, it was one time and it's awful for those interactions and whatnot, but it's like we like allow that hurt to carry on with us for so much longer, and we're like the only loser in that, right? Like the other person's not gaining anything or losing by us
No,
sitting in it.
no, not at all.
Yeah,
Really. And I think that a phrase, a catchphrase could be, where attention goes, energy flows.
for sure.
Mm-hmm.
And you talked about, this is going back a little bit, but you talked about how our idea of attachment is formed when we're like 4, right? Or
It's
3?
set by the beginning of the 3rd year.
Beginning of the 3rd year. Okay, so that attachment, is that like the styles of like anxious attachment,
Yeah, you got
avoidant?
it.
Okay,
You got
so
it.
that's when it first forms?
Yes.
Wow. And so how do you move past one of those attachments? Like how do you, if you have the anxious attachment style, and then say in your 20s or 30s you're like, Okay, I just wanna be healthy attachment style. How do you rewire, and can EMDR.
Yes. There are studies that show a transition from, an insecure attachment strategy to secure attachment strategy. And by the way, EMDR is not the only way that this can happen. It can happen through attachment focused psychodynamic therapy. It can happen through, you know, neurolinguistic programming. It can happen through other reconsolidation evidence based treatments. But in EMDR, the person's adaptive information processing is really being challenged for its validity in the present day.
Mm.
And that doesn't just start happening at the fast, bilateral stimulation piece of it. It's really starting with the attachment to the therapist, in which the therapist ideally is going to be um, presenting him or herself as that secure base, the safe haven that wasn't the way it needed to be to develop a secure attachment in the very beginning. That in an EMDR combined not only with the therapeutic relationship, but with what the adaptive information processing system inherent in every human being um, does in the reprocessing is to reformulate the way things are maladaptively linked in those file cabinets in the brain, in the files in the file cabinet in the brain.
Yeah.
Yeah.
And so there is when going into EMDR, is the goal an end where you don't need EMDR anymore?
Yes.
Okay.
The goal of any psychotherapy is to become independent of the therapist.
And how many sessions does that typically take?
Oh, I get that question so often. Typically
For
where people
sure.
call me on the phone, how long is this going to take? Uh, it really depends on how complex the person's internal system is. With a person who doesn't have hangups, if I can say that word, about themselves in the world, they don't have like a victim mentality. They have a secure attachment, but maybe let's say like they got into a car accident and now they have PTSD. They can't drive in a car anywhere. They're having nightmares. They're not able to get to work. Their life's falling apart. That person who doesn't have other um, other pieces of their history that would qualify them as having a complex internal system, that person could probably move through a treatment regarding the car accident with the PTSD in, 10, 14 sessions.
And then on the larger scale of things,
Mm.
probably like, well, a lot.
Yeah, people who are very complexly organized have dissociated parts of their personality. And we're not just talking about maladaptively linked memories in the brain. There are maladaptively linked ways of being in the brain. And so when somebody has a very serious history of trauma, particularly in the early years, relational trauma in particular, the person's internal system is in constant desperation mode. And when a human being isn't old enough to survive on their own and they can't escape, and they're, you know, at the mercy of their caregivers, who, for the most part, are the ones who are providing those unfortunate experiences, this child will escape in their mind, escape in their way of being. So as the body and the brain are developing and this is going on, it actually changes the development of the brain.
Whoa.
And so treatment in these cases is prolonged.
And change the development of the brain where can you see that change? Or is it more just like, okay, this is now a neuro network that is just like solid or something?
Well, yes, there are markers
Mhm.
in the brain that are different.
Okay.
Developmentally speaking, constant cortisol production um, will cause the brain to interpret much more in threat prediction ways than the average human being, and that gets repeated over thousands and thousands of experiences in daily life. And yeah, it's going to be pretty tough to change that because the ways of being that a person needs to develop um, are behind curtains of consciousness. I'm really talking about dissociative identity disorder right now.
And dissociative identity, is that very similar to personality disorder, multiple personality
That's
disorder?
the older phrase that
Okay,
we used to
got it.
use, but the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision. You told me not to be technical,
No,
and here I
no,
am.
it's great.
It's DID,
Got it.
dissociative identity disorder.
Okay.
Yeah.
And in DID too, this is like not related to cancer as much, but I've heard that in DID, one of the hosts can have certain health in like things versus a different host. So like one host
You
can
got
have
it.
diabetes
Yep.
and the other one doesn't.
There's hard data on this. Yes.
But it's like so mind blowing.
Well, that just gives you a glimpse into I'm getting chills. That
Yeah.
gives you a glimpse into how complexly organized the human condition can be in the brain.
What are other health differences that you see between hosts in DID?
I'm not
Or
understanding
like
the
what
question.
other health differences can exist in different it's hosts, right? In DID, or like what
I
are they
think that
called?
we're trying to get away from that name
Oh, okay,
hosts.
okay.
I like to use the phrasing of, a way of being
Fronting. Okay.
fronting, and a way of being in daily life
Mm,
that's much more welcoming to people's experience,
yeah.
as if the host and then other ways of being are not major.
Yeah.
So, m try to stay away from phrasing that, devalues other aspects of complexity inside a person. Yeah,
Absolutely.
but to answer your question about what can show up in terms of differences, we've talked a bit about attachment strategy, attachment, people say attachment styles.
Mhm.
Um, yeah, different ways of being behind curtains of consciousness can have different attachment strategies or attachment styles. So we see that as well. Um, I've had a client, I'm thinking of one in particular, in which they uh, knew how to speak a certain language, and that way of being inside didn't know how to speak English. Of
Wow.
course, the person, knew that language growing up in that different country,
Yeah.
right? So it's not something that like magically appeared, right? But that way of being only spoke that language. And when I would try to speak in English back, um, there was a recognition, but the response was always in that other language.
And I've seen it where one way of being like has a different eye prescription
Mm-hmm.
as well as the
Yeah.
other way of being.
Yeah.
Was so interesting, and it really points to how much our mind and body are connected too, of like,
Yes.
and that's really helpful throughout the diagnosis
Mm-hmm.
experience, because it's like,
Mm-hmm.
we get so caught up in our body as we go through something like cancer, but it's
Yeah.
like we need to really pay attention to the health of our mind too, and like that's going to impact how well we receive treatment. It's going to
Mhm.
impact how we perceive this journey that can last years as well.
Yes.
Yeah.
I feel the need to say that not only for a cancer journey, but for many other challenges with the body. It's a very common experience where people are perceiving the body as the enemy.
Mhm.
And it's important work to do, in my opinion, to help the person see what's happening as information, to take the value judgment off of it and the pressure um, to make it bad. It's, of course, unsettling and difficult, and life isn't the same afterward. I'm not minimizing that. But that fighting mentality um, can turn dark, and I would advise against that.
Absolutely. Can you tell me a little bit about your own run-in with cancer and if EMDR played a role at all in how you navigated it?
Yeah, thank you for bringing it up. So, I have never been formally diagnosed with cancer. However, when I turned 50 years ago, I went in for my requisite colonoscopy. And lo and behold, I had many colon polyps, and a few of which were precancerous. And the medical doctor who performed the colonoscopy said, wow, if you had waited even 6 months longer to get your colonoscopy, these likely would have turned cancerous. So as a result, I did some genetic testing, and I, in fact, do have the MUTH gene, MUTYH, which is a recessive gene, and it's a genetic mutation in which there's a much higher risk of developing colorectal cancer. So as a result, I have the distinct pleasure of getting colonoscopies at most, no, at least every 5 months. And every 2 years at this point, I have an endoscopy.
And what's the difference between an endoscopy?
One is the upper GI and one is the
Oh,
lower GI.
okay.
So, um, where you have a colonoscopy, that's where they're really looking at the large intestine.
And did you, throughout that process, did you ever feel like, oh, my training in EMDR really like helped me through this on navigate this health issue? Or have you already just ingrained certain mechanisms in your brain so that it was natural?
I wish I could say the
Yeah.
latter was true, but I still have my baggage that I'm working through like any human being. It never ends. My therapist told me, Christine, it never ends, the work. Really, you know that, right? I'm like, yeah, thanks.
You're like, yeah, thanks for
Yeah.
the reminder.
So what I went through initially, it was a shock, right? You get that shock feeling, and my life, I'm like playing out, the worst case scenario immediately before I could even catch myself, right? Um and so what I know as an EMDR trainer is that I need to be very, very careful about what I tell myself, because my subconscious mind is listening. And the subconscious mind is meant to be in a supportive role of the direction of the conscious mind. So if I'm telling myself something really bad is going to happen, the power of my subconscious mind will follow and obey.
Mm-hmm. It's like steering the ship.
Yes. So I know that, and I'm very careful about what I allow myself to think. I of course, catch myself, and I have my moments and sometimes my days. But it's so, so important to make sure that anything in my life that happens is information that I can use.
Yes. And how do like intrusive thoughts play into this? Like, you'll just be going along driving and then you just like imagine a car just like hits you. Like I feel like that's so common and I know I used to have them all the time, especially with cancer. I'd be like,
Mhm.
the scan's gonna come back bad or like anything, right?
Mhm.
What's going on there? Why do we have those intrusive thoughts about like the worst case scenario?
Yeah, that's a really good question. And that's particular to PTSD, I would say. So in your case, maybe it was like a medically induced PTSD because the intrusive experiences, whether it be through nightmares or sensory fragments or visual scenarios that just pop in without your conscious direction of thinking about the troublesome event, that really is the brain telling telling us, don't forget, remember this, this is really important, be on the lookout, because the brain wants to survive. The body wants to survive. Our DNA wants to survive. And so the part of the brain, and there's an interesting study that just came out in 2025, Kearney et al. From Nature Mental Health, um, talking about the brain and how the cerebellum is a master threat prediction area of the brain. And it's not just the amygdala, the 5 alarm fire part of the brain. So what's happening is that the normal bottom up to the prefrontal cortex processing that, when we have an emotionally charged memory that maybe, we want to think about to work our way through. In PTSD, that largely doesn't happen because the brain is all about threat detection and threat prediction and organizing and adjusting behavior in order to survive and adapt. So in PTSD, the brain, and in particular the cerebellum, is reverberating, heavy, in order to help the person do their best to make it in life. And this is all unconscious.
Yeah, it's so powerful.
Yeah.
But yeah, it's trying to help us for sure. But it's just doing it in an alarming way sometimes.
Well, yeah, I mean, it is alarming when you're thinking you're having a good day, and then all of a sudden you're thinking about the worst thing in the life that's happened to you, and you don't want to, but your brain is telling you you need to think about this.
Yeah. And I've been now when those thoughts come up, I've been trying to switch it to like the best case scenario that could possibly happen. And when I first started, I was like, this is hard actually. What
Yeah.
is the best case? Like what could and then as I practiced it, it was like those positive associations could grow, and I feel like it's really lessened the intensity of the
Yeah.
intrusive thoughts for sure.
Right.
What are some other studies that you like to mention or like to share with people?
I think in particular with PTSD and medical trauma, um, it's important to have the therapist do, whether it's EMDR or another modality, really, to take a bottom up approach. And what that means is that the threat prediction part of a person's experience needs to be addressed so that the higher brain functions can be a part of the party. So, in terms of medical trauma, let me say that it would be important to, and then Kearney et al. Is and Bethany Brand and colleagues, book Finding Solid Ground, published, I believe it was, I think 2022 or something. There's a cadre of neuroscience researchers. This isn't EMDR in particular, are really locking in on how we can address the threat prediction parts of the brain and help the person lock in on safety cues. Not to forget what's important in terms of being aware and dealing with past trauma, not to forget that, but the brain just seems to get overzealous with the threat prediction stuff.
Yeah.
So doing a bottom up approach in which, bodily based safety cues are focused on, and in particular, tailored to the bodily sensations that were originally, if I can say, assaulted by the experience, to notice that, to be able to be in the body and to have safety cues in those sensory modalities can be vastly helpful to train the brain to bring in the higher cortices and the higher functions to shed light on the experiences that are challenging and have a more full-bodied, literally full-bodied way to deal with, the bad stuff.
Absolutely. And before someone gets to the point of needing EMDR, what are ways that we can prevent traumatization when going through seemingly traumatic events?
Well, you know, eh, there are a certain percentage of people who go through traumatizing events, and I'm not talking about traumatizing in an objective way,
Yeah,
because it's very much a subjective experience.
for sure.
There's a certain percentage of folks who will spontaneously remit from the intrusions, the nightmares, the sensory fragments, the hypervigilance, the irritability, all the factors that go into early PTSD, which is called acute stress disorder. So little, a little less than half in the general population will remit from that, and then the rest will end up with PTSD. And so when you ask me about how can a person prevent that, um, what our research shows us is that people who have a pre-existing level of resiliency to begin with in their internal system are the ones who have that balance of thinking through feelings, feeling into thinking, who have positively adaptive social supports, who don't have a lot of mistrust in life, suspiciousness, anxiety in general, based on, repeated relational trauma in the past. So, I don't want to say that there's nothing a person can do, but I do want to say that staying present with the experience is preferable, being mindful, and then reaching out for help if that's unmanageable. If a person notices that they're slipping in their ability to function in day-to-day ways, it's really important and okay to reach out. I do believe that as a result of the COVID epidemic, mental health treatment has become so much friendlier all around the world, really. So previously, it was, considered in many cultures and in many parts of the world to be a weakness to have to reach out for therapy. But nowadays, that's one of the silver linings of COVID, I think, is that
Yeah.
therapy is much more integrated into, popular culture, and insurance companies are, loosening up, their reimbursement for mental health professionals to engage in treatment with people.
Yeah, and it's like also if you're going before it was like if you're going to therapy that means something's wrong with you, but
Right.
now it's like, oh, you're going to therapy that things are right with you. Like it's such a flip,
Yeah.
and I'm so grateful for it
Yeah, me
too.
too.
And like a lot of people will be like, "Oh, I won't date that guy unless he's going to therapy,
Therapy.
whatever."
I've heard that before.
Yeah. And I heard too on the PTSD part too, on being present with it. I remember listening to this like study they were doing about like they could predict during 9/11, right? They have so much footage of people running out of buildings and all of that stuff. And there was like this model where they could predict who was going to have PTSD depending on their facial expression. So like the people who were present in that grief and just like screaming or sobbing or like emoting versus the people who were just like checked out, dissociating in a,
Yeah.
in a sense,
Yeah.
those people were gonna be more
Mhm.
like probable to have PTSD. And so I feel like what you're
That
saying
adds
about being
up.
present,
Yeah,
yeah, it's
that
like
adds
don't
up.
just shove something away and
Mhm.
then it's gonna come back. Like you can't just ignore it, right?
Well, I think it's responsible for me to have something to say about the example that you
Yeah.
gave. So The folks who were exiting, the Twin Towers, running down Lower Manhattan, or, who were just kind of standing outside with blank stares and so forth, that's a telltale sign, as you had said, of dissociation.
Mm.
Dissociation is an involuntary, subconscious
Mm.
response to overwhelming experience.
Yeah.
So it's likely that a good portion of those people who were dumbfounded, so to speak, did have, some internal complexity that prevented them
That makes sense.
from being present with the terror of it all,
Yeah.
right? But that's not to say that some of those people who were dissociating afterward, I mean, anybody will dissociate if you give them enough, terror.
For
Really, it
sure.
will happen. Uh, a good portion of those people, probably shook it off afterward, but that was a momentary response. But a portion of those people did likely have complex internal systems to begin with. And when that's the case, dissociating can become a one size fits all coping mechanism, in a snowball effect,
Yeah.
even when it's not overwhelming trauma, but just a small stressor in daily life.
Absolutely. And I remember reading that you do a little bit of hypnosis as well. Is that true?
Yes, clinical hypnosis, right.
Okay.
And that's really important, um, to be able to have that in my toolbox. Clinical hypnosis is an intervention. It is not a full therapy modality.
And how does that work when someone wants to go through hypnosis for um an intervention?
I usually will let the person know. I mean, I can give you formal introductions, formal inductions. However, it's best used within the frame of another therapy, such as talk therapy
Mm.
or EMDR.
And so what do you use hypnosis for versus use EMDR for? Is it like different issues that they're coming in for?
In my particular practice, I incorporate clinical hypnosis into what I'm doing,
Okay.
particularly when people do have complex internal systems and their subconscious mind is very tangled up with maladaptive memory networks, and the logic brain isn't cooperating either.
Yeah.
So clinical hypnosis is widely known as being able to directly go into the subconscious mind and bypass the logic brain.
Mhm.
It's a
And
more direct route for complex internal systems.
yeah. Okay. Yeah, cuz so but how do you really get people to be hypnotized? Or induce them, I guess. How do you induce them?
So much so, if formal inductions aren't commonplace these days in the
Mm.
clinical hypnosis community, although they are done. It's more of a conversational
Yeah. Okay.
hypnosis. Yeah.
Okay. Is that happening right now? No,
No.
I'm just kidding.
I know that's usually the question that happens right
Really?
afterward. Yeah.
Because 'Cause they're, like, scared that you're gonna be like or something?
And I might want to say right here is a good place that many of the preparation exercises in EMDR are actual clinical hypnotic interventions. But we
How?
don't call it clinical
Yeah.
hypnosis because technically speaking, anything that is guided imagery can be clinically hypnotic.
Okay, so it counts as clinical hypnosis when someone is just, like, remembering something, like, from the past? Is that what it is?
No,
Or
I think that the dividing line might be that one would be if the therapist is trained in clinical hypnosis to do formal inductions to bring the person to an internal state in which there's a loosening of the normal strictures in the conscious mind and to be more receptive, because the subconscious mind, and I'm not even talking about EMDR anymore. That's okay.
no, but it's, like, ties
But
together, though.
the subconscious mind learns by repetition, the five senses, and suggestion. And in therapy, we're using positive suggestion.
Mhm.
And so guided imagery fulfills all of those criteria.
I see.
So there's a blending.
Okay. And what success story of one of your patients or one of your trained professional patients just like really sticks out to you that you'd want to share today?
Oh gosh. Well, I can tell my own story before I
Perfect.
was trained in EMDR. Okay, so I have been a single mother a long time. And after my divorce from my kid's father, um when the kids were with their dad for, like the 5-day stretch, we had a a schedule in which it was a 2-2-5. And I found in particular that on the 5-day stretch when the kids were small, really small, they used to like to sleep in my bed sometimes, or at least cuddle, and then I'd take them to their beds. When they were on their 5-day stretch, it was really tough
Mhm.
for me. And so I became very disheartened at the notion of going to sleep. I would get this really in the pit of my stomach, like somebody had stabbed me in the stomach,
Oh,
and in my heart it felt empty. And I said, I don't want to live like this. I've heard about EMDR, so why don't I try it?
that was your introduction to it.
Well, that was my motivation to go and check it out,
Okay.
because I had heard that it promotes rapid healing,
Mhm.
right? And um, so I went, and the therapist, did the phase 1 and the phase 2 prep, and it really only took, um, a couple of different memories to reprocess, and I never felt that again.
That's incredible.
I know. That's why I said, "I've gotta get EMDR basic trained."
Yeah, and you're like,
Yeah.
"Now I need to spread it to so many people too." Wow. Yeah, I do think it helped. I was an insomniac for like a decade and if not more. And I feel like EMDR really did help me get over that
Yeah.
too. And because that's when I first started seeing
Mhm.
some positive trend. And of
Mhm.
course, not identifying as an
Mhm.
insomniac. That's
Yeah.
super important too. Okay, what do you wish that more cancer patients knew about EMDR or about mental health in general right after they get a diagnosis?
Mhm. Um That no matter what happens, there can be a trajectory that is life affirming and resourcing. It's not all bad news.
Beautiful. Is there anything that I should have asked that I haven't or that you wanted to cover?
I did want to mention Francine Shapiro, the
Yeah.
founder of EMDR therapy. Um, if it weren't for her initial cancer diagnosis around the late 70s, maybe early 80s of breast cancer, EMDR may not have been developed.
So she started it after getting the diagnosis
Yes.
because she was
Sh
traumatized.
Well, I don't know, but I do know that she was pursuing a PhD in English literature. And
Mm.
she decided to drop that line of academic study and really intently focus on um, psychoimmunology. And so she went to graduate school looking at the stress immune system connection. And that's how EMDR was born.
That's amazing. And
Yeah.
she got over through her diagnosis.
So she was initially diagnosed, then for many, many, many years, she was cancer free. And then in her later life, and it's unclear when, she got another cancer diagnosis, but I don't know how close to the end of her life. But she passed on June 16th of 2019,
Wow.
and she had another cancer diagnosis, but the details of that are not really available.
Totally.
Yeah. She died at 71.
Wow. And it has made such a big difference in this space for sure. And what I love about this topic is like how much hope is just like instilled in it of like the patterns of our behavior or our trauma or our triggers, like they're not gonna be forever with us. And there's something
They don't
that
have to be.
they don't have to be. Yeah, we have tools out there that we can tap into to get over these humps as long as we're willing and want to and ready to
Yes.
like open up and
Yes.
get over. So
Yeah.
that's just really reassuring.
Yeah.
And
I
thank you
think so
for
too.
all of the work that you put in. Where can people find more about what you do and support you and all of that stuff?
Well, the EMDR Center of Southern California, we're an EMDR International Association approved program for training mental health clinicians. So if you're a mental health clinician out there and you want to become EMDR basic trained, you can go to our website, which is EMDR California, all lowercase, all one word, .com. And we have many facilitators who are also expert in EMDR therapy. So if you want, there's like a therapist directory on there. as well.
Amazing. Okay. Well, I'll put that in the show notes
Okay,
too.
thank you.
Thank you so much for being here and all the lives that you affect.
Absolutely. And thank you as well.